Hey everyone, and welcome to Chef AJ Live. I'm your host, Chef AJ, and this is where I introduce you to amazing people like you who are doing great things in the world that I think you should know about. Well, today is the first Monday of the month, which means it's time for McDougall Monday. And Dr. John McDougall today will be talking about livers and liver disease and what diet might have to do with it. Please welcome him to the show. Nice to see you, Dr. McDougall, as always.
Well, it's just so good to be back with your very enthusiastic audience, and you too, AJ. I look forward to this month.
We love your presentations. And in case you guys don't know, every Sunday at 5 p.m. on Dr. McDougall's YouTube channel, he does a live Q&A with questions you sent in. And last night, I thought was especially good when you were talking about the history of cancer.
You know, I was going to start out, because I think this is so important. I was going to start out by going over some of this discussion I did last night, and then we'll talk about liver afterwards. Because I think it's really important that we start getting the job done. I mean, we start changing the way medicine is practiced. This is just terrible. So those of you who are listening, if you listen carefully to the first 20, 30 minutes of the presentation I'm going to give, if you are a patient, if you feel like you're not involved, if you feel like you're not getting your questions answered or not getting answered honestly, or maybe there's another part of the story you should know, then please pay attention and get involved, because you're being mistreated. It's called malpractice. I don't know any other way to say it, but it's just plain and simple malpractice. And, you know, if we were dealing with your TV set or even your car, if it broke down, hey, we could buy another one, but we're dealing with you and your spouses and your children, your parents. Don't you expect a level of honesty here that exceeds repairing your car or your television set? I do. And I want to bring you up to date on some things that we've been talking about for years. In fact, I started writing about this in 1984. Oh, probably earlier than that. Now, McDougall's Medicine, A Challenging Second Opinion, I wrote, published in 1984. You know, there's so little that's changed since then, except I've kept it up to date. You know, people ask me sometimes, why don't you rewrite your books? Excuse me, I wrote them right the first time. Now, there's some room for updating, and I'm going to do that for you. I used to do it in the newsletters that I put out, but I stopped writing them. But what I do now is I do videos and I do presentations, and I try and bring you up to date on the scientific literature. But, you know, probably you need to go back and look at some of my previous videos. Like we're going to be talking about heart disease and cancer during this first section. Well, you know, if you're kind of at a loss as to what I'm talking about, you know, go to YouTube, the YouTube channel, and put in McDougall and heart disease or McDougall and cancer, and get up to speed. And then listen to this presentation again that I'm going to give you right now, because I'm building on stuff I've been working on for 40 years. And I'm not exaggerating. I'm not, you know, I have no vested interest except for the fact that, you know, I'm a doctor, and my loyalty is to patients. And many of you are my patients, and some of you are indirectly my patients. At least I hope you bring me into your consulting room with your physician and you discuss the material that I've shared with you, and ask them, hey, is this true? You know, if you don't get thrown out of the person's office within 7 minutes, that's what you're allowed, is a 7-minute office visit, then, you know, maybe you'll have a chance to talk to this physician, this healthcare provider. And maybe, like Chef AJ will tell you sometimes, and my daughter Heather always tells me, Dad, there's a lot of really great doctors out there. You know, you're always kind of bad-mouthing your colleagues. Well, you know, in general, I'm covering it like it is. But yeah, there are some exceptions. There are some physicians out there, nurses, dietitians, et cetera, that have the same attitude I do. And that is that you are the one that counts. And you need to know the truth. You know, not people's opinions. You need to know the facts. And so what I'd like to do with you just for this moment, and I'll keep doing this as we give presentations along the way, because I'd like to bring you up to date on diabetes, on autoimmune diseases, women's problems, and so on. And, you know, when research comes out, I just want to add on to what I've done already, because like I said, I did it right the first time. So let's talk about some of the things that concern me that have come up all over the last year or two that I think you should know about. And if it doesn't make a lot of sense to you, go back and look at the basic presentations I gave you on, well, in this case, on heart disease and on cancer. Look up the studies. See if we can get this in line here. All right, you tell me we're all set here. We got a good picture there, Chef AJ?
Perfect.
To get you involved, I've got to get you're doing your homework, all right? I've got to get you to look at the basic research and decide whether or not I'm exaggerating. I mean, how could Dr. McDougall be right and everybody else be wrong? How could that be? Well, you can find out. You can challenge me. I encourage you to do it. In fact, I insist you do it. I'm going to ask you for each and one of the discussions I bring up to look up the basic papers and read them, particularly if this concerns you. Read the basic papers, the scientific papers, and decide whether or not I'm telling you the truth. How do you do that? How do you look up the basic scientific research? Well, I've shown you, and I'll show you again. You go to PubMed, the National Library of Medicine, and you look up the title of the article or the subject you're interested in, or you look up the reference that I provide in the bottom right-hand corner of the slides. And what you do when you look up the presentations on PubMed, the National Library of Medicine, is they'll give you citations. They'll tell you how to look things up. Well, what you look up is you look up something called the DOI. It's right there. It's under. Let's look under Cite. DOI. You look up Digital Object Identifier, DOI, and you copy that number. And then you go to this website that you see here, Sci-Hub. Sci-Hub is a renegade website that provides for you the scientific research. I mean, the basic papers are right there. And pretty much I can find pretty much everything I talk about by just going to Sci-Hub. But also, I would say about half of the papers available are open access. So they don't even try and disguise them behind copyrights. The publisher is going to tell you, look, this is copyrighted information, and to go to Sci-Hub is cheating us a lot of money well deserved. Excuse me. The research papers were done courtesy of your tax dollars. They're done courtesy of the money you spend on buying their products. This is your research. You paid for it. I don't feel bad in any way for you having access to it, even if they say it's copyrighted. Anyway, you know how to do it. You find the DOI number. You put it in Sci-Hub, SCI-HUB. Okay. And right now it's housed in Russia. You can see the identifier SCI.HUB.RU. It was held in different countries. They'll move it around, but it's available for you. Look it up. Take the papers into your physician, your healthcare provider, and say, look what I learned. Is this true? Come on now, is this true? All right, let's see if we can get moving along here. We're going to talk about some updates on topics that we've been over before. You know this because if you went through if you just listened to me on Chef AJ, the presentations I've given, they're all on YouTube. They're all free. And if you've taken the 12-day program, boy, we've given you the basic understanding. And the nice thing about you being involved in the 12-day program is you're a McDougall patient. Yes, you are. That's the only way you become a McDougall patient. You either have gone to my St. Helena program, St. Helena Hospital, which I did for 16 years. It's one of the best hospitals in California. I was there for 16 years. If you were a patient there, then you're my patient for a lifetime. Or if you go to the resort program we ran in Santa Rosa, California for 18 years, you're a McDougall patient. And if you attend the telemedicine program, which we've been running for the last 3 years, 12 days of your life, you're a McDougall patient for basically life. Not only do we give you the 12 days, we schedule weekly appointments and then monthly appointments with you. Hey, our goal is to get the job done. The one night stands are over, folks. I don't do that anymore. A 7-minute office visit is very unsatisfying, not just for you, but for me. So if you really would like to get involved in your care, you say, I've had it, it's too painful. It's too painful to suffer the diseases, to suffer the unsightliness. I used to really like what I saw in the mirror. You say to yourself, well, you can have it back. You can regain your lost health and appearances. The body heals, but you got to stop damaging it with the food. Yeah. All right. Let's see if we can get on to some topics here of interest. All right. Let's talk about lying to the public. All right. Lying to the public. When it comes to heart disease, I gave you the information. I showed you all of the studies that were done to date on doing PCI, percutaneous coronary intervention, or angioplasty. I showed you all the research up until what I'm going to show you right now. And also on open heart surgery, I showed you all the research. And what the research said, the European study, the veteran study, the CAS study, that was the coronary artery surgery study. They all say the same thing. Open heart surgery does not save lives. Maybe in the very, very, very sick it does, but not for most people who have open heart surgery. And when it comes to angioplasty, whether you, whatever study you look at, they all show the same results. There's no survival benefit to doing these kinds of interventions, but there's a lot of reason to do them. I mean, heart bypass surgery, the open heart surgery where they rip your chest open, they put you on the heart-lung machine. That's $70,000 to $200,000 if all goes well. And an angioplasty is like $30,000 to $100,000 if all goes well. And it doesn't always all go well. So there's tremendous motivation to keep you in the business. Here it is. It's money. All right. So let's talk about let's talk about what's been done in terms of advancement of knowledge in heart disease. What we're talking about is coronary artery disease, atherosclerosis, plugging of the arteries of the heart so that you don't get enough blood supply to the heart. Let me bring you up to date. But first, you understand, without argument, heart surgery does not save lives. And maybe in the very, very sick. We'll see. But that's not what you're told. You're told you'd be stupid not to have this surgery. Okay, doc, if that's the case, show me the evidence. Show me the research. I've made available for you all the research that was done up until what I'm going to show you right today. It's nothing more important than you and your family. And the consequences can be huge. It's just not a matter of wasting $30,000 to $200,000 or more. It's a matter of having your mind work, of risking death. Yeah, this is important. Well worth a little trouble on your part. Okay, malpractice continues. Unchecked heart surgery. Well, heart surgery is done on hard fibrous plaques. You see, this is an angiogram, and you see the arrows pointing here. They're pointing to hard fibrous non-lethal scars. These are stable. They don't rupture. But that's what doctors operate on, is they operate on these scars. They bypass these scars, which basically never kill. But what kills instead are plaques that rupture. What happens is the inside of your arteries gets damaged by the foods that you eat. Maybe tobacco makes an additional damage factor here, but the foods damage the inside lining of the arteries, and you see a thin layer here called the intima. One cell thick, that's all it is one cell thick, and the injury occurs. Globs of fat, slivers of cholesterol get under this thin skin, and just like a sliver stuck in your hand, a sliver of wood, the body reacts. It tries to isolate that sliver. It tries to remove that sliver, just like it tries to remove the slivers of cholesterol and globs of fat in your artery walls. It does this by infiltrating the injured area with an inflammatory reaction, with white blood cells. And what you end up with is a pustule just like you would if you stuck a sliver when you're in your hand. You get redness and swelling and heat and pain. And then if you left it in there, you wouldn't, because you have nerves in your hand. You have no nerves in your heart artery to tell you the same thing's going on or similar. If you left the sliver of wood in there, eventually pus cells would surround it. You get a pustule. And you may at that stage decide to rupture the pustule and take the sliver out. You may or may not. If you left the sliver in there, it would eventually be covered with scar tissue. And that's what the lesions are I showed you in the last slide. They're scar tissue. But what happens and what gives you a heart attack is this. Let's follow the arteries progression down. You get the development of a pustule, a sore, and the sore gets bigger, and the outer layer of the sore becomes thin, and you develop a fissure, and out of the fissure comes spurting inner contents of this pustule. Yeah, what happens is the pustule pops like a pimple rupture on a teenager's face, and it causes the blood to clot. And it's the blood clot that kills the brain tissue or the heart tissue or other tissues in the body. It's not the hard fibrous plaques, it's a sudden rupture of a plaque. Okay, but doctors don't operate on the killing part of the disease, the rupture that forms a blood clot, which results in a coronary artery thrombosis. Why? Because they have no technique. They have no treatment for that. So what they do instead is they operate on the old scars. All right. So now you got some basic understanding of what goes on with this disease. Let's take a look at some of the recent studies done here. 2009. That's one of the latest studies, a randomized trial of therapies for people who are really sick. They've got type 2 diabetes. They're overweight for almost for sure. You got high cholesterol. They've been shoved on that rich American diet into their artery walls for years. These are the most sick of all. And what you see is you see no survival benefit. Look at the charts. Survival of revascularization, in other words, doing angioplasty versus medical therapy, 88.3 versus 87.8, not significant. Anyway, here's another study you want to confront your doctors with, where they looked at coronary intervention. Overall, there was no significant difference in the rates of death or major cardiac events between patients undergoing prompt revascularization or those undergoing medical therapy, or between strategies where, part of the strategy in this study was to intensively treat diabetics. So you made your hemoglobin A1C close to normal. But we've already shown that doesn't work. I went over all that with you in the diabetes section. In fact, that kind of aggressive therapy kills. That's what all the studies say, but we won't touch on that today. All right, so a more recent study. This was done in 2022. Okay, October of 2022, just published, New England Journal of Medicine, the best of the best. Now here again, they looked at the very sickest people, the ones that have such damage to their heart muscle that half the heart muscle's dead. You'd expect if the procedure works at all, you'd expect to see the benefits in those who are very ill. Okay, well, it took them a long time to find these 700 people that they were studied who were very ill. They were on average age 70 or older. They found 700 patients. And among those with severe ischemic left ventricular dysfunction who received optical medical therapy, revascularization by PCI did not result in a lower death rate from any cause or hospitalization for heart failure. In other words, the surgery didn't cause them to live any longer. But you know why? It's because they operate on hard fibrous plaques. They don't do anything with the killing part of the disease. All right, so I hope you have that established well in your mind, that this expensive procedure, which you risk your life having done, plain and simple doesn't work. There are, I'll go over 20, 30 studies with you or your doctor, and there'll be no argument here. The only argument would be is, ma'am, sir, go find another doctor. I'm done with you. Yeah, you might lose a few physicians by asking questions, but hey, all right. So let's except in the most severely ill. Bypass surgery or any type of open heart surgery or angioplasty does not save lives. Well, an angioplasty, plain and simple, doesn't save lives. Maybe open heart surgery, and the most severely ill would a tiny bit. Yeah, tiny. Okay. Anyway, here's randomized control trials. A couple of them there for you, huh? All right. So if heart surgery doesn't save lives, then why would you do it? Are there legitimate reasons for doing it? And yes, there are. If you have such severe closure of your heart arteries that you can't get around, you can't do the things you want to do. You know, you can't prepare your own meals, you can't go windsurfing, you can't ride your motorcycle, whatever is incapacitating to you. Heart surgery can relieve chest pain. But you should only look into it if it's incapacitating chest pain. In other words, if it's something you don't want to do again, it's not incapacitating. I mean, if it's a matter of climbing up to the top of a mountain that's 10,000 feet high, you might say to yourself, I really don't want to go up there anymore. But if it was something that's near and dear, say to me, like windsurfing across the pond at 34 miles an hour, I might decide that that's incapacitating and have something done. What would I have done? Well, according to standard teachings that were taught to me 50 years ago and are taught to doctors today, is you should reserve surgery for people who have incapacitated chest pain unrelieved by good medical therapy. Now, good medical therapy is supposed to be drugs that relieve chest pain, like nitroglycerin, calcium channel blockers, beta blockers. Then you can relieve the chest pain. Then you don't need the heart surgery. Why? Because it doesn't save lives. All right. Let me explain to you how you do relieve chest pain with really good medical therapy. Here's a picture of the blood flow. You see the blood flow here? This rapid blood flow through the heart arteries. You imagine going to your brain, good blood flow, and then you eat fat. And what happens is the fat coats the blood cells and they stick together in clumps. And you see this dramatic reduction in circulation here right before your eyes. The circulation stops. A dramatic decrease in blood flow to the heart muscle or to the brain. The studies show that you drop the amount of oxygen in the blood between 5 and 15% after one single high-fat meal. And this sludging lasts for about 10 hours. So wouldn't it be nice to relieve chest pain by stopping the sludging and improve the amount of oxygen in your blood? Don't you think that would be a good thing to try? Well, here's some research done, and I want you to look this up, okay? I've given you the reference in the bottom right-hand corner. Here's some of the studies. I'll show you the rest of them in just a minute. This is a study done by Mike Friedman. I used to know. He was a famous type A, type B personality person. Mike Friedman, Meyer Friedman, whatever, he did experiments along with Peter Quo and a guy named Williams, and you'll read about these people because you're going to read about all these studies that were done in the 60s, 70s, and finished up in the 80s. This right here represents a change of circulation that occurred in a person. This was a 44-year-old fireman who had no apparent, just an average American, you know, the usual high-fat, high cholesterol stuff. And what they did is they took a microscope and set it up over the conjunctiva of the eye, the whites of the eye, where you can see the blood vessels. You know, you look in the mirror in the morning and you see these blood vessels. Well, that's what they're looking at. And then they fed this man a diet that contained 67% of their calories as fat. One meal. What did that meal consist of? Well, 2 strips of bacon, 2 eggs, 4 strips of bacon, milk, cream, bread, and 2 pats of butter. One meal. And you see the dramatic reduction of circulation that occurs in the right-hand picture. Same area of the eye. Vessels have disappeared. Oxygen contents drops about 5 to 15%. It's the lack of oxygen to the heart muscle that causes the pain. Okay. Doesn't this seem to lend itself to a good way of treating people who have heart disease? I mean, the surgery doesn't work. I just showed you. But the drugs will relieve chest pain, but minor as far as the benefits go compared to what was done by Peter Quo and his associates This was back in 1955, it was published, and you're going to look it up in the Journal of the American Medical Association. What he did is he took people with narrowed heart arteries that were getting chest pain. He took 14 of these people. And in his selected population of 14 people, of 14 people, 6 of them developed chest pain after meals. They developed 14 episodes of chest pain after they ate in these 6 participants. All right, so what they did is, if you look on the chart on the right, is they look at the turbidity of the blood, how thick and creamy it looks. And creamy means you have high triglycerides and a lot of fat in the blood. That fat that coats the blood cells, like I showed you before, that compromises circulation. All right, here's an individual here, and you see his they call it lactescence, or it's the creaminess of the blood. You see, or triglycerides, you could think about that. You can see after he eats, he doesn't have any chest pain. And then here in about 2.5, 3 hours, you see the X's there. He has 4 episodes of severe chest pain. It occurs about 3, 4, 5 hours after that one single meal. So what if you stop doing this? What if you stop feeding a high-fat diet to somebody who has narrowed heart arteries? You get rid of the indication for doing heart surgery. Probably, let's not even guess how many people, but you'd save a lot of lives, wouldn't you? Sure you would. Sure you would. What they say in here is postprandial lipemia. That's the fat in the blood, okay? That's the fat when you stick the tube of blood on the counter, and this layer of fat forms like when you stick a pot of chicken soup in the refrigerator. You look back a couple hours later, there's this layer of fat on top. That's what we're talking about. All right, postprandial, after you eat, lipemia may exert a deleterious effect on the myocardium. A low-fat diet may well be useful in the management of patients with angina pectoris, in other words, chest pain, as a measure to help prevent their pain. And by the way, the diet that stops the chest pain is the same diet that reverses the underlying pathology. Neat, huh? All right, here are the studies. I put them up here for you. Inquisitive medical students, patients, or medical doctors, or cardiologists, or heart surgeons, or whoever you may be. Here's the research. Look it up. But it's been forgotten. Even in the face that, tens of millions of dollars, they do 100,000 bypass operations a year, or more than that, about 200,000 a year in the United States, about 500,000 open heart surgeries, and over 100,000 angioplasties a year. And they don't save lives. They're done for chest pain, unrelieved by good medical therapy, incapacitating chest pain. You did not give your patients good medical therapy if you didn't change their diet. That's malpractice, in my opinion. Now, there is a circumstance, and I want to tell you this little caveat here, because it's important, is it takes a while after the pimple pops and the blood starts to clot before it becomes irreversible. If you have severe chest pain and you can get to the hospital certainly within 6 hours, probably within 90 minutes, you can get up to the cath lab and you can have the cardiologist drip blood clot dissolving medication on that blood clot. It'll preserve heart muscle. It may keep you alive longer. But the intervention has to be applied within 90 to 120 minutes after it starts. After that, the clot's organized. The heart muscle's dead. The heart surgery couldn't help. So if you have sudden chest pain, hey, get to the hospital really quick. But most of you don't go to the cardiologist for that reason. You have chronic coronary artery disease, which clearly, without any question, survival is not improved by doing angioplasty or open heart surgery, except in the maybe with a few very sick people. All right, the final study done, and there are no more researchers done. I mean, this is passé. This has been forgotten. This doesn't fit into the financial statement of keeping the medical businesses healthy. But let me tell you about the last study done. This is done by a professional friend of mine, Dr. Dean Ornish. We've been stomping the bookstores together for the last 40 years. I remember when I would follow him on a book tour, trying to sell books. There was Dr. Ornish's books out there and my books out there, and I turned his face in and mine face out. But he still sold a lot more books than I did. I thought maybe not. Anyway, Dr. Dean Ornish, and he did in 1983 did a study on people who had severe coronary artery disease, and within 3 weeks he got a 91% reduction in chest pain episodes by the same diet that I use, that he's been using, that should be used, et cetera. They're not going to do any more studies, ladies and gentlemen. There's no reason to. All right, so there's the lying to the public when it comes to heart disease, and they're still lying. They're not going to stop. You've got to prepare yourself as a consumer. Now let's talk about the cancer business a little bit, because that's one even my colleagues are afraid to challenge the oncologists over. There are a couple professions, and both of them I would apply this statement: the emperor wears no clothes. You see, if you're emperor, you can tell people to shut up, don't look, don't believe what you see, because they are the most vulnerable to being caught for lying. Cardiologists and oncologists are, because they tell the biggest fat lies of anybody. I just showed you what the cardiologist and the heart surgeon is doing. Let me show you what the oncologists, the people who deal with cancer, are doing. Not that they don't have well-meaning intentions, but you're being hurt. Okay. Colonoscopy is the standard it's the gold standard. In fact, if you try and get a sigmoidoscopy, which I do recommend, you'll be denied. We say we don't do this. It would be malpractice, they say, to just examine the last 2 feet of the colon. We got to examine the whole 6 or 8 feet of the colon. They say it would be similar to just doing a mammogram on one breast, to just do a sigmoid exam as opposed to a colonoscopy. Well, we can go over the mammogram stuff at another time, and I can tell you, that's another lie sold to the public. But let's stick with colonoscopy here for a minute. Here's the reason it's so popular. Cost over $3,000 for a colonoscopy, done at a surgical center or a hospital. It requires anesthesia. The complication rate is not too high, but it's important if you happen to be the one that suffers the complications. About 7% of people who have polyps removed have serious complications. About 7%. When it comes to one of the most troublesome complications, and that's the perforation of the colon, that occurs in about 1 in 2,000. And about half the people who have a perforation of the colon die. But you're asked to have this potentially deadly procedure done. Whereas sigmoids, it's done in an office, no anesthesia, virtually no complications. And the results when you do a sigmoid as far as survival are as good, if not better. I can argue they're better than when you do the colonoscopy procedure. Okay, this is a malpractice that continues to date. Sold to the public. You'd be stupid not to get your colon fully examined, you're told. All right, well, I have to establish something here first for you, is that when you do studies, what you do is you set them up so that they're randomized control trials. That's how you determine whether something works or not. That is the gold standard, is to do an experiment where you have a big group of people, you divide them into 2 similar groups, the control group and the intervention group. Okay, in this particular screen, you're looking at the screen group, of those who get the mammography or the colonoscopy, et cetera, versus those who don't, or get a lower frequency. If this procedure really works, then at the end of the study, we should see more people alive in those who had the intervention than in the control group, and we don't. We don't. It's not a matter of finding tumors earlier. You still die the same day. You just found them earlier. If you're not looking, you find it, say, 3 years before you die. If you're looking intensively, you might find them 10 years before you died. Well, it just means you knew you were sick longer. That's all. You still died the same day. What you need to see is in a randomized controlled trial, when you apply what you believe to be true, you need to see more people alive who undergo the intervention. And it's highly questionable whether any of the screening procedures done today show this kind of benefit. Certainly not a benefit you'd want to buy if you really understood what was going on. All right. I have to teach you the natural history, just like I had to explain to you about heart disease. I've got to teach you the natural history of cancer. And once you know this, then everything makes sense. So please pay attention. A single breast contains 100 billion cells. So 2 breasts, you've got 200 billion cells. A single prostate contains 100 billion cells. I mean, just try and consider how many cells that is. Well, cancer starts as a single cell that stops obeying the rules. Always one cell leads the way. This cell stops obeying the rules, and one of the rules is you can't go dividing anytime you want. You can divide if you're growing, or if, say, you have an injury to repair the wound, you can divide. Otherwise, you can't divide anytime you want. Otherwise, you'll become a misshapen lump in an hour or 2 hours or a few hours. Okay, so a cell gets injured and decides it's not going to obey the rules. It's going to divide its own free will. Not like wildfire. The average doubling time for a solid tumor is every 100 days. That's every 3.5 months. So one cell in the breast or one cell in the prostate becomes cancerous. And it starts dividing. So 100 days later, you've got 2 cells. 100 days later, or 3.5 months later, you've got 4 cells. And then you've got 8, 16, et cetera. You've had cancer for a year, and you've got a tumor mass that consists of 12 cells. Amongst 100 billion, you can't find those. It's undetectable by any means. The divisions continue. And by the way, many cancers that are said to be cancers really don't manifest themselves this way. But there are many who do, too. So let's continue with the divisions. Every 100 days, finally, you're at 2 years, you've got over 100 cells, still can't find it. Divisions continue. You've got a tumor mass the size of a period on a paper, size of a lead tip of a pencil. It contains 1 million cells. It's been growing for 6 years. 6 years. It's still not detectable by any means that we have available. Okay, so let's get it to the detectable stage. Divisions continue, and finally, you're at 10 years of doubling. You now have 1 billion cells in your tumor mass that is the size of an eraser of a pencil, 1 centimeter. It's now detectable. You can feel it. A mammogram may find it. The PSA starts to become elevated for prostate cancer. It's a 10-year-old disease. This is not early detection. This is late detection. And if it's truly cancer, in a lot of situations, it's not. It would have never affected you. But it's truly cancer. It's spread to the liver, to the bones, to the brain. The cattle are already out of the barn before you close the door. How in the world would any intervention matter at this stage, particularly local interventions like surgery or radiation? Do you understand what I'm telling you? Do you understand that you're looking at a disease that's, 6, 10, 20 years old? On mammograms, the average time of doubling before they're detectable is 14 to 17 years of doubling. The reason is mammograms detect slower growing tumors. Now, let me tell you something here right now, is that the average is every 100 days. For some people, for some tumors, they double more rapidly, like every 25 days. That's not good. But whereas for other tumors, they'll double not every 100 days, but say every 300 days. That's good. You know, say you have breast or colon or prostate or lung cancer or brain cancer. You just want to delay your time of death. We're all going to die, folks. So you want to slow that tumor down. You want to stop feeding it the things that cause these tumors. You want to enhance your immune system so you're on the winning side of this battle. Okay, now understanding this, you will now be able to understand why early detection is really late detection. Remember, you're not going to find it on average until it's 10 years old in terms of doubling. It's 1 billion cells. Then you can find it. That's early detection. As far as treatment goes, you have to understand that if it's truly cancer, and I have to tell you, many people, in fact, probably 10 times as many people are overdiagnosed as are truly diagnosed with the cancer. In other words, they're told they have cancer and they really don't have anything that will trouble them in their lifetime. Anyway, you'll understand why there are treatment failures. And we're going to talk about both early detection failures and treatment failures here. You're being lied to. This is out of Johns Hopkins. This is their discussion of how a colon cancer develops. Just to show you, I'm on the same page with everybody else. And so will you be if you start studying this a little bit. Okay. People on the Western diet, somewhere between 22 and 58% of them have precancerous polyps. They don't know it from eating the Western diet. These cancerous polyps, precancerous polyps, and colon cancer don't exist in populations that use starch-based diet. This is a disease only in Western living. It's from poisoning the colon with bad food. All right, so once you damage the cells in the colon, what happens is they respond by proliferating. That's what smooth muscle cells do, they proliferate. And so you see here on the left-hand side, you see some hyperproliferation to try and cover up the injury. And this hyperproliferation, it gets worse as time goes on. And these little lumps of tissue become bigger and bigger until they're finally big enough to call them a polyp. They're about maybe a centimeter in size, yeah. And then you see the divisions. They're a precancerous polyp, and then finally they're a cancer, and they're able to grow inside through the tumor walls, the cell walls, into the bloodstream and spread throughout the rest of the body. It takes, depending upon which research you look at, between 5 and 20 years for this to happen. And I think more fairly, it takes 15 years before you go from a normal colon tissue to a cancer. It takes 15 years. And it takes another 15 to kill you. You'll be 90 years old by the time you die of this disease. On average. Unless screening works, unless colonoscopy works. All right, Journal of the American Medical Association Internal Medicine, love this journal. They often have a article called Less is More. In other words, guys and girls, stop over-treating your patients. And what they point out in 2016 is there's no randomized clinical trial or high quality evidence showing that colonoscopy reduces colorectal cancer mortality. But that isn't even overall mortality, which is really the key factor. It really, is this going to save your life? Are you going to have more people alive in the screen group than in the control group? The only way you can tell. Well, it's gotten to the point where you're considered a second-class citizen if you don't follow your doctor's advice. In fact, you should be ashamed of yourself. You should feel guilty if you don't get a colonoscopy done. Embarrassment can't kill, but colon cancer can. Get a colonoscopy. This is a billboard. There's no better way to get a colonoscopy. One way, do not enter. Cover your butt, get it. This is every place. You'd be stupid not to get a colonoscopy done, wouldn't you? Well, when this study came out, which we're going to talk about in just a minute, this study came out in October of 2022, the only randomized control trial ever done on colonoscopy. I'm going to show you in just a minute. Some of the media got it right, like, for example, in the news stations, NBC News, they said colonoscopies may not be as effective as thought, study suggests. Doctors disagree. Why do they disagree? Why would they disagree with the data, with the science? You know why? How about Nature? Controversies over colonoscopy for colon cancer screening. There are controversies because the truth is different than the sales pitch. That's why. All right. Here's the one you take to your relatives, your well-meaning friends, and maybe even to your attorney. Maybe. Okay. First randomized trial ever done. And I'm going to divert for a minute after I get done telling you about this. I hope I remember to do that. The first randomized trial ever done, it was a trial, it was done in Europe, Poland, Norway, Sweden, got involved in this trial. And what they tried to do is they took a control group, which got, casual colonoscopy examinations, and an intensive study group that got, frequent colonoscopies. They had intensive colonoscopy done by experts. Look at the chart. Look at the cumulative risk of death. The invited group who had the colonoscopies versus the usual group. In other words, screened versus control. Now, what they show, well, if you can't read the chart there, look at the bottom left-hand corner. Died from any cause. Those who underwent colonoscopy for 10 years, 11.03% of them died. Those who didn't, who were in the usual, the casual, and by the way, in Europe, colonoscopies are not recommended for their population. In Canada in 2016, they told their citizens to not get a colonoscopy. So these people in the usual care group, they weren't getting colonoscopies. The intensive care group, they were. And what was their death rate? Usual care, 11.04%. In other words, what is it, 0.01%? And it was in favor of those who didn't get colonoscopies. I'm reading that right? Invited group? Yeah, no, I think it's backwards. 0.1%, that's it. But you better get your colonoscopy done or feel bad about it. I mean, there's $3,000 per intervention at stake here. Well, do I recommend a colonoscopy? No, not at all. Science shows it doesn't work. What do I recommend for colon cancer screening? I recommend between the ages of 60 and 75 that you check your stool for blood or for genetic material. Just check a stool, non-invasive. You just, rub a little stool on a stick. And or get a sigmoid done, one sigmoid, that's it. If you're fully covered by anybody's assessment, you're fully covered. But you try and get a sigmoid done in your town, I guarantee you they won't do it until you show them this study. Copy it. I showed you how to get it. Copy it. Take it into your gastroenterologist's office. Let them sweat and squirm and tell you why this isn't true. If they try, you can always give them my email address and try and convince me it's not true. All right. What I wanted to say to you about this randomized control trial and the next one that follows is my colleagues, cardiologists, oncologists, cancer specialists, heart specialists, et cetera, they say it would be malpractice to not treat somebody or to not do these tests. How could you possibly even suggest it? And that's the reason there are no randomized control trials done on treating lung cancer or uterine cancer, is because my colleagues knew the natural history of cancer and how it grew and how you couldn't find it until it had been growing for 10 years. And by that time, it was too late and treatments couldn't possibly work. They knew that, or should have. So what they've done for the last 50 years, I've been in this business for over 50 years. They've done hundreds of thousands of these tests and treatments. If they had any inclination that they could show by a properly done study that these were to the advantage of a patient, don't you think they'd have done it? Then they wouldn't have had to take and lie to the patient, embarrass you, make you feel guilty to get you involved in the business. Anyway, let's go on. I've talked to you about early detection. It's late detection. Let's talk about treatments. Same thing I'm talking about. This is malpractice, but let's go over it anyway. Let's talk about treating breast cancer. For my whole career, 50 plus years, certainly 47 past years, I've recommended that if a woman has a lump, she has it removed with clear margins. So just take the lump out, pretty much non-deforming, depending upon the size of the breast and the size of the tumor. Nothing more. Not an examination of their lymph nodes under their arm. No, don't do that. Not mastectomy. No, don't do that. I haven't recommended that at all. And there's actually a fraction of our community out there, the ones that aren't general surgeons, that don't do mastectomies, don't make their living, send their kids to school based on tuition paid for by, operating, amputating breasts. There's a fraction of my colleagues who are more progressive who say you don't have to do this mutilating surgery. You don't have to take a woman's breast off. When I first started, I even before I went to medical school, I was a surgical nurse, and I've been on hundreds of these operations. But back when I first started, we used to take the breast, the underlying muscles, and all the lymph nodes on the side. But before I started practice, back at the turn of the century, they used to take the arm also on the affected side of a woman who had breast cancer. All right, so we started realizing that we don't have to be that aggressive. And I'll show you why we realized this, because of Bernard Fisher, and his study started in 1970s. I'll show you. Your doctors know this, or should know this. Anyway, the standard of practice is this: if you don't have your entire breast removed, which is, it has to be done sometimes, but most of the time it can be avoided. That if you're going to get a lumpectomy, you must get an addition of radiation. And I've been told because you'll live longer. And that's what the studies say, but they don't say that. I have had arguments with medical students, with fellow doctors, who tell me, this is malpractice for you to not give this radiation to women who have a lumpectomy, just the lump removed. But I say, look, radiation causes a leathery breast. If you do it on the left side where the heart is, you double the risk of dying of heart disease. It suppresses the immune system, and it's a bit costly. Radiation therapy, $13,000. Anyways, lumpectomies are, the radiation costs nothing when I have it done. In other words, I don't recommend radiation. All right. So here is a study on men. Now, I bring this out because I want to make a statement for you before I get too far into this. I want you to know that still today in the United States of America, males dominate the business. As the caregivers, it's mostly male still. That's being fixed by admitting a lot of young women or older women to medical school these days. So it's kind of being evened out. But traditionally, through my entire career, it's been a male-dominated medical business that takes care of women. This is sexism that's going on here. Why do I say that? Because we've studied prostate cancer in men. We've studied the effect of treating men by removing their entire prostate, or by radiating their prostate, or by doing nothing. It's called watchful waiting. So we've given our male counterparts a real advantage when it comes to, we're not going to let us guys be mistreated by girls, whatever. And so we started studies. This is 15 years. It was just published in 2023 in April of this year, showing that there's no difference in survival whether you have the prostate removed or even more aggressive surgery, which you can hardly believe there's more aggressive, but there is, or radiation, or doing nothing. So have we evaluated the effects on women of, doing nothing? I would say you should have the lump removed, yeah. But how about adding radiation? Which I guarantee you, your doctor will insist that you have not just lumpectomy, but the addition of radiation. And then you say, based on what evidence, doctor? Because you've done the research, you've looked up the studies, right in the bottom right-hand corner, you go into the National Library of Medicine, you've looked it up, you got the DOI number, you put it into Sci-Hub, and you've got the study right there. So you're prepared for the doctor when the doctor says, you'd be crazy, ma'am, not having the radiation done, it'll come back and kill you. But how about men with prostate? By the way, prostate cancer is analogous to breast cancer in women. Yeah, basically the same disease. Same causes, same natural history, same failure of treatment, same. Okay, but we're giving advantage to men. I have to point that out because, just because. All right, let's take a look at the research done on women and the addition of radiation. Remember, we'll let men go without any more aggressive therapy, but how about women? Well, Bernard Fisher, he was a big researcher during my years of education, Bernard Fisher. He did the classic study, which started in the 70s and was finished up in 2002 after studying women for 25 years. Take a look at the chart. Take a look at the chart. Overall survival. Look at it. Look at it. If you take the whole breast off, okay, that's the squares. You do a lumpectomy only. That's the triangles that are open. Or you do a lumpectomy plus radiation. That's the triangles that are closed. Still looks the same to me. How about to you? Does it look the same to you? There's no difference in survival in any of the three groups, just like in men. But I assure you, you go to the doctor and you have a lump, you're not going to get away with a simple lumpectomy, much less have the doctor discuss with you the importance of eating well. Okay. All right, old research, this has probably been all disproven, God, good grief. All right, well, I reviewed the studies because I was involved with some of my students, and they insisted that I had to be wrong, that I was hurting my female patients by not adding radiation. So I looked at the research, published it in my 2017 newsletter, and basically what it comes down to is, after looking at 22 randomized trials, there's no benefit in terms of survival. Okay, but let's do a really good study. Let's do a really good study so that nobody will question what goes on. Published in February 2023. Remember, I told you I do follow-ups in these kind of lectures. I do follow-ups of the new research to see whether or not maybe I missed something. Okay, breast conserving surgery with or without irradiation in early breast cancer. Look at that. Look at the numbers. No radiation. Percent alive at 5 years and 10 years. No radiation, 94.2%. With radiation added, you drop 0.5 of a point. Why? Because some people die from the treatments. At the end of 10 years, survival, 80.8, no radiation therapy. 80.7 if you got the radiation. You slap this study on your doctor's desk and see what happens. I'll bet you'll get thrown out of the office. That's what I'd guess. Anyway, there's the data. There's nothing else. So when you put it to the test, when you do the randomized control trials, what you find out is what I've tried to tell you from the beginning. They start with premises that are incorrect. You know, with heart disease, you start with the idea that it's the hard fibrous blockages that cause heart disease. It's not. It's the tiny pimples that pop, which we have no treatments for. If you understand the natural history of cancer, you'll understand by the time you can find it, it's already expressed 2/3 of its disease unbeknownst to you or the doctor. 2/3 of the illness has already occurred, unbeknownst. So what happens when you discover the disease? Now you become a customer. Early detection means there'll be longer times to treat you with more therapies. It's the money. Yes, it is. Be funny if it wasn't you and your family. But it's not funny. Anyway, you're welcome to share this presentation with anybody you want. And my email address is really easy to find. Be glad to discuss with you these subjects on Chef AJ's show if she'd like to. I don't know. I do know because of mass communication, because of what we're doing right now. I have a chance to talk to you personally, to share with you this information, and we're going to change the world. I am so excited about what's going to happen over the next 4 to 5 years, because the truth will get out. The truth is simple and easy to understand. The truth's the truth, ladies and gentlemen. You can't, no matter how much publicity you do, no matter how many spin doctors you hire, you can't change the truth. All right. So anyway, Chef AJ, would you like to stop for just a minute and see if there are any questions?
Absolutely. I will look in the chat. I know that there have been questions that were submitted, especially about liver disease.
Well, I'll go on and do the liver disease thing if you want, but I just had to tell you this. You can imagine the frustration I have for you.
Oh, yeah.
For you as a patient, because you'll be told things like, a well-meaning doctor will tell you, look, if you don't have this tumor cut out, you're dead meat. And if you submit to my surgery, I will cure you. That's what they tell you. They may not say it in those exact words, but that's the message that comes across to the patient. They're sitting there all upset. All they can hear are the words of condemnation or hope. And what they hear is, you got a problem. Yes, I got a problem. Okay, I got a tumor in my liver or my colon or my breast or whatever. And you're telling me I'd be stupid to not have the most aggressive therapy possible. Well, doctors, show me the evidence. Show me the research. You don't stand a chance unless you come well.
Dr. McDougall, Nancy's saying, she's agreeing with you, and she's saying, well, what about people that take their body parts out, not even when a tumor is found, but just because they have a gene, like, for example, the BRCA gene?
Yeah, that's true. Let me tell you how you reduce your risk of lung cancer in half. You cut out one lung. Let me tell you how to reduce your risk of breast cancer in half. Do you know that there was a magazine that I read? It wasn't a medical journal, but there was a magazine that I read early in my career that said, because breast cancer is so common, it occurs in 1 in 6 women in their lifetime on the Western diet. It's only a disease of Western civilization. It doesn't occur when people eat a starch-based diet. This magazine suggested that just like we perform circumcisions on little male babies days after their birth, we should remove the breast buds of female babies during the same post-birth period of time. Then you will eliminate breast cancer. Excuse me. Is that an approach you'd want to take? Yeah, if you catch it early enough, then you can make a difference. As far as BRCA goes, BRCA and 1 and 2, these are genetic problems that set you up as having a tendency towards more breast cancer. But if you eat a starch-based diet, this is not important, because my understanding of this disease is even if you have the genetic tendency, it's not going to affect you. And the interesting thing about treating BRCA, this genetic problem, is that taking the breasts off doesn't improve survival, but taking the ovaries out does. And we've talked about over and over and over again how it's estrogen that promotes cancer, breast cancer. And that's why it is a disease primarily of women. Women have it 100 times more frequently than men because of estrogen. If you take estrogen pills, hormone replacement therapy, you increase your risk of breast cancer. Therapies that lower estrogen slow the growth of the cancer and you live longer. These therapies can be tamoxifen, aromatase inhibitors, or you can have your ovaries taken out. When it comes to BRCA, removing your ovaries is what makes a difference, not taking your breasts off. So if that was the approach you were going to take, well, first thing you do, eat a good diet. There are just so many factors in a good diet that make a difference. So you eat a good diet. And then what you do is you reduce your estrogens. First thing you do is you lose that excess body fat, because fat cells make estrogen. The fatter you are, the more estrogen your body contains, the less osteoporosis you'll get, but the more breast and uterine cancer you'll get, because of the high estrogen levels. So you lose the weight, that helps. Change the diet. There are dozens of mechanisms involved in lowering estrogens when you eat a plant food-based diet. And by the way, these are discussed in chapter 5 in my book, The McDougall Program for Women, which you can, well, Heather gives it away once in a while. But if you want to read it sooner than giving it away once in a while, as we do, as many of my books would give away, you could buy it on our website for like $10. Anyways, it tells you some of the mechanisms involved that lower estrogens when you eat a plant food-based diet. So, yeah, in answer to your BRCA thing, you can get body parts cut out. Sure, you can. You reduce your risk of breast cancer and uterine cancer, colon cancer. Let me tell you another one. In people who have familial polyposis, this is a genetic condition where you develop thousands of polyps in the colon, and they have a very high risk of developing colon cancer. In these people, if you divert the flow of food away from the colon, in other words, you do an ileostomy, so that the contents that you eat never goes into the colon, these polyps disappear. So maybe what we can do, in addition to taking your breast buds off and taking one of your lungs out and cutting one of your, we're going to take the breast buds off, so we don't have to do that. The guys would take your testicles off. That would take care of your testicular cancer risk. We can also, right after birth, after we get done taking the breast buds off and the testicles off, we can do ileostomies on every little baby so they won't get colon cancer. I know you think I'm being silly, aren't I? I'm trying to tell you that, look, you want to do the easy way. You want to do what's right. You understand this disease, these diseases. Anyway, the indication for heart surgery is incapacitating chest pain relieved by good medical therapy. Good medical therapy is a change in diet. Chest pain goes away. Ornish published a 91% reduction in chest pain episodes in 3 weeks. You won't even be able to get your heart surgery scheduled for the next 3 weeks. You got time to figure this out. Anyway, you're being lied to. Look it up. Take these papers to your doctor. Ask your doctor, okay, you're making the recommendations. You are the recommender. I'm the patient. I haven't gone to medical school for, medical training for 7 to 10 years. I haven't done that. You have. since you're the recommender, I want you to show me that you'll do me more good than harm. I, as Dr. McDougall, or you as patient, shouldn't be put in a position where we have to disprove them wrong. But we have to, because they won't support what they're doing. Why won't they support what they're doing? Because it doesn't work. It causes more harm than good. Why did they do that? Because that's what they were trained to do. It was like Leonard Kim. Leonard Kim, when I was in my probably first year in general practice at Castle Hospital in Kailua, Hawaii. Look him up, Leonard Kim. He's probably gone. He'd be probably dead now. It was a very, very, very good surgeon at Castle Hospital. Leonard gave a lecture on mastectomies. Oh, this must have been, 40 years ago. And Leonard gave a lecture, and he going through the research on mastectomies and whether or not prolonged survival. And every single study showed the same thing. No survival benefit. And I said, Leonard, I went up to him. I knew him on a friendly basis. I said, look, tell me something. I said, if I heard you right, you just said that cutting off a breast, no matter how aggressive you are, does not prolong survival. Did I hear you correctly? He says, yeah. I said, look, I got the surgery schedule here for this afternoon. You have 2 mastectomies scheduled. One happens to be in a 93-year-old woman. I said, what's going to stop this, Leonard? He said, a whole bunch of surgeons trained differently. Do you really want to wait that long? Till your doctor gets up to speed on the science? You have another question now? I'll go on to the liver thing if you want.
Yeah. The only other question I thought was really interesting in the chat, Dr. McDougall, is when people get like cosmetic surgery on their breast, she's
Right.
asking, Christina is asking, can that aggravate underlying cancers?
I don't know. These breast implants have been of great controversy. I certainly would not recommend them. I can't think of a reason that that I would want one of the female members of my family to have augmentation. As a doctor, I've seen many, many female chests. It happens to be one of the privileges you have as a doctor to, examine your patient, know what they look like, and their problems are. Well, I've seen thousands of women with their chests. That's been part of my physical exam. And I can tell you, I have never found a breast augmentation that I would want to have any woman I know wear. They're like 2 rubber balls sitting on the chest. I'll take you back to when I was a surgical nurse. Before I went to medical school, my job was working in the operating room. And I remember we got a call over to, the woman was asleep. Okay, you may not like this. It happened 50 years ago. Okay, I know it's wrong, but this is what happened. Is after she was put to sleep, we were all called into this operating room. And she had the surgical sheet over the top of her, and it looked like she had 2 rubber balls under the sheet. And this was the first augmentation I'd ever seen. And of course, patient asleep, she was undressed. And all of us in the medical field got a chance to have a big laugh. I know it's wrong. Anyway, I'll tell you the other side of the story is in all my years of practice, and I've taken care of probably 40, 50 women who've been in this situation where their breasts were too big for what they thought was functional, much less attractive. And they went through breast reduction surgery. I have not met a single woman who wasn't thrilled with having her breast size reduced when necessary. So I don't see it. I don't get it. Why 2 rubber balls would be attractive or add to somebody's appearance. Okay, so I don't know that the usual stuff is that these silicone implants cause autoimmune diseases. That's been to trial. There's been a lot of money at stake. I know many women who swear up and down that this is what destroyed their life. And I tend to believe them. Yeah. But anyways, it's not one of those arguments I'll probably get into. There are not enough people that would be addressing. I would rather deal with heart disease and breast cancer and colon, that kind of stuff, real common stuff that we can all benefit by getting the truth. Any other questions, Chef AJ?
No, that people are just like wanting to hear more about the liver, and there's questions about liver disease.